Welcome everyone to today's webinar. Today we're going to be talking about the CMS health equity measures and the Joint Commission requirements to reduce health disparities. I'm Laura Benzel and I'm one of the health equity leads for iPro. So as always, it's great to hear from everyone and thank you again for joining us. We would appreciate you entering any questions or comments in the chat. We'll be responding to them throughout the presentation. We may not have time to answer all of the questions, so we encourage you to enter all of them in the chat, and we'll be addressing any outstanding questions as we're able after the event. We'll send those responses to the questions that we did not address during the webinar to all attendees. We appreciate you staying muted throughout the duration of the presentation to reduce background noise. So the sponsor of today's event is iPro. iPro leads the CMS Hospital Quality Improvement Contract for these 12 states, and they collaborate with the organizations that you see listed on the slide to provide technical support targeting identified high-priority patient safety issues in rural hospitals, critical access hospitals, and acute care facilities serving vulnerable populations. iPro is also the lead for the CMS QIN-QIO contract for these 11 states and the District of Columbia, collaborating with health-centric advisors and Clarent to ensure high-quality, safe healthcare for 20% of the nation's Medicare fee-for-service beneficiaries. So I'm very pleased to introduce our guest speakers for today's webinar. Julia Venanzi is the program lead for the Hospital Inpatient Quality Reporting Program and Hospital Value-Based Purchasing Program, Quality Measurement Value-Based Incentives Group, Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. Christina Cordero is the Project Director for Healthcare Standards Development in the Division of Healthcare Quality Evaluation at the Joint Commission. So Julia, I'm going to turn the presentation over to you.
Thanks very much, Laura. As Laura mentioned, my name is Julia Venanzi. I'm the program lead at CMS for the Hospital Inpatient Quality Reporting Program and the Hospital Value-Based Purchasing Program. I thank you very much for having me today. I'm here today to talk through some of the new health equity related measures that we adopted in the hospital IQR program this past year in the fiscal year 2023 IPPS final rule. Next slide, please. As a quick reminder, the hospital IQR program is a pay-for-reporting program for subsection D acute care hospitals. The program excludes psychiatric hospitals, rehab hospitals, long-term care, and children's hospitals, as well as the 11 PPS exempt cancer hospitals. The program also excludes hospitals located in Puerto Rico and other US territories. So under the hospital IQR program, CMS requires that these hospitals, the subsection D acute care hospitals, meet certain requirements each year, for example, submitting quality measure data. If an eligible hospital does not meet those requirements for a given year, their annual payment update will be reduced by 1 quarter for that fiscal year. The data that gets submitted under the hospital IQR program also is then publicly posted on the CMS Care Compare or Provider Data Catalog website for public transparency. Next slide, please. So as I mentioned today, I will focus specifically on these first 3 measures here that are related to health equity, but I did include a list of the full list of 10 measures that were finalized in the rule last year, just as a reference. I can send around some additional resources after the fact that cover some of the other measures here if that is of interest, but I will focus on just the first 3 today. Next slide, please. So starting first with the first measure, the Hospital Commitment to Health Equity Structural Measure. We finalized the adoption of this measure beginning with the calendar year 2023 reporting period, which impacts the fiscal year 2025 payment determination. So we believe at CMS, we believe that strong and committed leadership from hospital executives is essential and can play a role in shifting organizational culture and advancing equity goals. So therefore, we finalized this first measure, which assesses hospital leadership commitment to both collecting and monitoring health equity performance data. So this measure is an attestation-based measure that will ask hospitals a set of yes or no questions regarding their commitment to health equity across 5 different domains. The first domain is related to hospitals' strategic plans as they relate to equity. The second domain is related to the collection of social determinants of health and demographic data. This domain includes questions on how and if hospitals collect demographic and social determinant of health data, as well as hospital training for staff that are collecting this type of data. The third domain is related to then analyzing that data that is collected. The fourth domain is related to the hospital's engagement in quality improvement activities that can improve the quality of care for all patients. And then lastly, the fifth domain relates to hospital leadership's review of performance data and the hospital strategic plan as they relate to health equity. So for each of these domains, there are between 1 and 4 sub-questions within each domain. The questions are yes or no questions. Hospitals will receive a point for each domain if they attest yes to all of the related sub-questions. For the measure for this as finalized for calendar year 23, there is no sort of partial credit for sub-questions. So for example, in order to get a point for domain 1, you'd have to attest yes to all of the sub-questions. If hospitals participate in or complete qualifying activities at any time of the year during the reporting year, they may attest yes to the question. So it can happen at any point during the performance period, which would run from January 1st, 2023, all the way through December 31st. To attest to this measure, hospitals will complete their attestation using the Hospital Quality Reporting System, or HQR system. Some of you may also know this as the QualityNet Secure Portal. So submission of this measure will be done through basically a web-based form within the HQR system. Hospitals will go in and attest there. For calendar year 2023, the submission period will run between April 1st, 2024 and May 15th, 2024. So submission will follow in the spring after the performance period. So next slide, please. So moving now to the second and third measure, these are 2 related measures that focus specifically on identifying health-related social needs. So to start with the first of the 2 measures, this measure is the screening for social drivers of health measure. So CMS defines health-related social needs as individual level adverse social conditions that negatively impact a person's health or healthcare and that are significant risk factors associated with worse health outcomes as well as increased healthcare utilization, just as background. So we believe that consistently pursuing identification of these health-related social needs will have 2 main benefits. The first is that social risk factors disproportionately impact underserved communities. Promoting screening for these factors could serve as evidence-based building blocks for supporting hospitals and health systems in sort of actualizing commitment to addressing disparities, improving health equity, through addressing these needs, as well as partnering within their community, and then implementing associated equity measures to sort of track progress. The second huge benefit is that these measures could support ongoing hospital quality improvement initiatives by providing data with which hospitals could stratify patient risk and to examine their organizational performance. Utilization of these screening tools to identify burden of unmet health-related social needs can be a helpful first step in identifying community partners and connecting individuals to resources within their own community. We believe that collecting data across the same 5 health-related social needs that were screened under the Accountable Health Communities model run out of CMMI, many of you are probably familiar with that. We believe that collecting the 5 that were screened under that model will illuminate the impact of those 5 on health outcomes and the care cost of burden for hospitals, in particular for hospitals that do serve a high proportion of patients with unmet health-related social needs. So with that sort of background context in mind, we finalized these 2 measures. So the first measure looks basically at the rate of inpatient admissions for patients who are 18 and over, who have been screened for each of 5 health-related social needs. Those are food insecurity, housing instability, transportation needs, utility difficulties, and then interpersonal safety. So when developing this measure, we thought a lot about how to best screen for these and how we could make it, I guess, easiest in this sort of first step to collecting this data. How could we make this easiest for hospitals to do this? And in thinking that through, sort of due to the, I think, variability across hospital settings and the difference in populations that they serve, we are allowing hospitals flexibility within this measure as finalized as it is now to select their own tool to screen patients. So I note that while we allow flexibility, we do have a number of recommended tools within the rule for hospitals that may not have one that they are using already or may not have one in mind. We do have a list of recommended tools, including the tool from the CMMI model. Next slide, please. So this measure, similarly, we adopted with a voluntary period in calendar year 2023, which then follows mandatory reporting beginning with calendar year 2024. Similar to the first measure, this measure will be reported annually. And again, it would be reported in the spring following the performance period. So for example, for the calendar year 2023 voluntary period, data will get submitted between April 1st, 2024 and then May 15th, 2024. This measure, as well as the next measure, will both also be reported within the hospital quality reporting system, the HQR system, via a web-based form. Hospitals will be submitting aggregate numerator and denominator data into the HQR system. Next slide, please. Okay, so moving now to the second related measure. The second one is the screen positive rate for social drivers of health measure. This measure will be calculated as 5 different rates. Each rate is derived from the number of patients admitted for an inpatient hospital stay who are 18 and older, who were screened for all 5 of the health-related social needs, and who screened positive for any of those. So basically, we're taking the denominator of the first measure and using it here. So that number is then divided by the total number of patients who were screened for all 5 health-related social needs. I did want to note that there are some exclusions, patients who opt out of screening, and then patients who themselves are unable to complete the screening during their stay and have no caregiver able to do so on their behalf would be excluded from the measure. Next slide, please. So timing wise, this is the same as the screening rate measure. This is finalized for adoption with a voluntary period in calendar year 2023, followed by mandatory collection beginning in calendar year 2024. And again, that would be reported in the spring following the performance period. Next slide, please. So the next couple of slides I just included for reference. Here I included the link to the FY 2023 IPPS final rule where we finalize these measures, as well as including the page numbers for hospital IQR, so you don't have to dig through the thousands of pages. I will also send out a few additional education documents that we have. They're currently posted on the QualityNet website if you're familiar with it, but I can send around a link after the fact. But these documents will include the measure specifications and a little bit more about implementation. I will note that we do have a couple additional education items forthcoming in the next couple of weeks, including an FAQ document, which I think would be really helpful. I will make sure to share that with Laura once that gets posted. And then next slide, the next, I think, couple of slides, I won't go through, but just wanted to, again, include here as a reference. They include all of the current hospital IQR program measures by year in case it's helpful for people to have that reference. So that is it for me. I will take a look at questions. As Laura said, I don't think I'm going to be able to get to all of these looking at the number of the chat, but let me just see.
Yeah, I think a lot of it is folks introducing themselves, but there are some questions, yeah.
Okay, perfect. Okay. Starting with the first one I see, will the attestation enumerator be asked via QualityNet? Yes, for all three of these, this will be done via a web-based form on QualityNet. If the patient is screened on prior admission, do they have to be re-screened at every subsequent admission? If screened as an outpatient, do they need to be screened again? The answer is so long as they are screened once in that performance period, they wouldn't need to be screened again, so long as that's captured. Similarly, if that data is collected in an outpatient setting and is in their EHR, that could be included for that patient for the hospital inpatient reporting for that year. Okay. Sorry, this is a long one. Okay, for this. Okay, for the screen positive rate of social drivers of health measure, the measure overview states the patient should be screened on the date of hospital admission. However, the measure calculations, the number of patients who were screened, our hospitals expected to screen on the date of admission is the summary there. No, the screening can happen basically anytime during the inpatient admission. It would not have to be on the first day. I think I covered the frequency. Our inpatient psych patients excluded. So long as they are admitted as a hospital inpatient, if they have a primary psych diagnosis, they would be included. We don't have exclusions at the patient level. But I will say for inpatient psych hospitals, separate from a subsection D hospital, those would not be included. This is solely for subsection D hospitals.
I think that's all the questions. Again, just encouraging anyone, if you think of additional questions, please enter them in the chat. We're happy to respond to them after the event. and we'll send out the responses to everyone along with the slides, which will also be posted on our website. Julia, thank you so much for joining us. Oh, wait, there's one more question.
What is the length of the performance period? It runs annually for all three of the measures that I talked about. So January 1st through December 31st of a given year. And that impacts the fiscal year, basically 2 years in advance. So the calendar year 2023 data impacts fiscal year 2025.
Great.
Does it impact star rating? Right now, these measures are not included in star ratings. And then, go ahead.
Yeah, I see a lot of questions about the slide deck. We will, in PDF format, be sending out the slides. Additionally, Julia has some resources that we'll be sending out, and we will send that to everyone who registered for the event and attended the events. And we also will post it on the iPro website. I think there are a few more. Yes, this session is being recorded.
Okay, so for the question, for the screen positive measure, do we use the numerator from the first measure? So all patients that were screened for all 5, yes. I think that's it, right?
Great. Dr. Cordero, if you want to, did I stop sharing my screen? I think I did. If you want to pull up your slides. Again, Julia, thank you so much for joining us. We really appreciate it. And I'm very happy to turn over the presentation to Dr. Cordero from the Joint Commission. Dr. Cordero, it's all yours.
Okay, great. Thanks. Hopefully everyone can hear me okay and see the slides okay.
Yes.
I am happy to be here today just to talk a little bit about some of the work that we've been doing at the Joint Commission around improving healthcare equity, particularly on the accreditation side with our standards. And then I'll share a few resources and some links similar to what Julia just presented, some links to some of the resources that we have that will help with implementation of these requirements. Okay, so most of the time I think healthcare equity is approached from the lens of social justice, but we really do consider this to be a quality and safety issue, and it really is a quality of care problem that has a similar approach. I think most organizations can take a similar approach to healthcare equity as they are taking to many of their other quality and safety priorities, just in the sense that they need to understand the root causes of healthcare inequities, and then hopefully they can address those with targeted interventions. We have several requirements in this area. We've been working in healthcare equity for several years. I think I've been at the Joint Commission just shy of 16 years now, and I've been supporting our healthcare equity standards this entire time. So there's this is just a list of standards that are throughout our manuals within our hospital program, and many of them cross multiple accreditation programs and settings. And just to point out that, we have a number of requirements here that are legacy requirements that, again, have been in the manuals for years, just around discrimination issues, collecting patient level data around race, ethnicity, and preferred language, a number of requirements around the patient's right to receive effective communication and language interpreting services, as well as several requirements that include things like health literacy and just make sure that patients have the opportunity to participate in care discussions, ask questions, understand the risks before they sign informed consent documents and things like that. But just that this issue of healthcare equity has been embedded in our manuals for years. But with this new project, we've really tried to expand the scope of what we're looking at on the accreditation side and the types of questions that our surveyors will be asking. Like many of your organizations, we also have a number of healthcare and equity initiatives going on within the Joint Commission. And we have our own internal efforts and a DE&I council where we're looking at diversity, equity, and inclusion issues within our staff and our workforce. We have a number of different publications that we've tried to release over the last year or so that address different healthcare equity initiatives and issues, particularly around our Speak Up campaign, which is a campaign that's focused on encouraging patients to speak up about their care and advocate for themselves. We've had a number of quick safety and sentinel event alerts related to healthcare equity issues. And then our publication in The Source had a 4 or 5 part series run last year on healthcare equity. We're also hoping to inspire organizations through our Tyson Award, which we do in collaboration with Kaiser Permanente, which acknowledges and awards organizations that are making a measurable improvement in healthcare equity. And I believe I just saw an email come out yesterday. I think the preview application for the Tyson Award is on our website now. So I encourage organizations that are, again, really striving for excellence in this area to take a look at that award application to see if there's a possibility for you to be recognized for the work that you're doing. And then, as mentioned in the beginning, I'm from our standards department. So I'm here to talk about our standards, both on the accreditation side, and then I'll give a bit of a preview on what we're doing on the certification side. But we've had a very busy year and hope to have another busy year this year in 2023, just with a series of webinars. And we've had a series of updates and significant updates to our website, and then a lot of work that we're doing on the resource side to make sure that our organizations have the types of resources and example practices that they need to implement the standards that we have going forward. So as I mentioned a little bit earlier, we've had a number of standards in our manuals for years that have addressed these issues, but I think the biggest difference with our current project is that we really wanted to expand that scope to look at healthcare disparities and equity initiatives as a whole. So really trying to encourage organizations not just to focus on the individual patient level needs at the bedside, but to look at assessing and addressing healthcare disparities within their patient populations. One of the terms that I know that has come up questions over the last few months, we did intentionally use the phrase health-related social needs. Again, Julia talked a little bit about that on the CMS side as well, but we use health-related social needs versus social determinants of health or social drivers of health within these requirements, because we really did want to focus on individual level needs that affect the health and healthcare of patients. And so while we encourage organizations to look at the larger scope of social determinants and social drivers of health, including investing in their communities and looking at education systems, the focus of these requirements and the kinds of things that our surveyors will be asking about are really focused on this red box on the right side of the slide, looking at just health and the healthcare interaction. So I'll go a little bit through, spend a little bit of time here talking about the new accreditation standard that we have in our leadership chapter. I'll go element of performance by EP, and then talk a little bit about the resources, and then we can take some questions at the end. So our new standard is LD 040308. This is in our leadership chapter, and we intentionally put it in leadership because, again, we feel that success in this area demands that leadership commitment and the leadership attention to this as a quality and safety issue. The standards were released in pre-publication form back in July of 2022, and they were recently implemented in January of 2023. We feel that these standards address foundational elements that organizations need to establish in order to advance on their healthcare equity journey. We know that organizations across the country are at different stages of that journey. So we wanted to create requirements that made sense for organizations nationally, but we know that for some organizations that have been doing this for a number of years, this may seem, like things that they've already been doing and maybe easier things that they can show the surveyor a lot of progress in this area. But we did want to make sure that we could also create requirements that made sense for organizations that may just be starting out to address some of these issues. Applicability, these new standards are applicable to all of our accredited hospitals in the hospital and critical access hospital program, as well as selected settings within our ambulatory program, primarily group practices that are looking at primary care that have more of these ongoing longitudinal relationships with their patients. So this standard does not apply in the ambulatory setting to organizations focused on episodic care or dental or ambulatory surgery centers, for example. We also have some limited applicability in the behavioral healthcare and human services program. I won't read all of that, but we're really focusing on the healthcare side of that program and some of the services being provided in behavioral healthcare settings. We did that because we felt the strongest evidence for supporting these requirements and the number of resources available were really focused on these particular settings. Not to say that healthcare equity issues are not important across the entire care continuum, but we really felt that we could have the most support and the most resources to help our customers within these particular settings. But that having been said, we will continue to monitor the literature. We continue to work with organizations to hear more about what they're doing in this area. And so there is a possibility that we could expand the scope of these requirements in the future. So as far as what the standard itself is, this is the leadership content from standard LD 040308. Again, I mentioned it's really focused on reducing healthcare disparities for the hospital patients and that being a quality and safety priority. We feel that this does include the commitment, it needs the vision and creativity, and this sustained effort across all levels of an organization, from the C-suite all the way up to the board. I think a lot of healthcare equity initiatives over the last few years have been pilot projects or some limited grant-funded initiatives, and we wanted to embed this into the leadership chapter, again, to focus on this sustained effort over time. It allows organizations to establish leadership and standardized structures and processes to make sure that they can detect and address healthcare disparities within their patient populations. And we do encourage organizations to think about including these efforts and integrating them into a lot of the QI improvement activities that you're already doing. Again, a lot of these standards, if you're familiar with our requirements, follow a very similar structure to some of our other requirements that are other quality and safety priorities. Going again, element of performance by EP. The hospital designates an individual, it could also be multiple individuals, to lead the activities to reduce healthcare disparities for the organization's patients. We put this requirement forward because it does establish these clear lines of accountability in terms of who your point person is for your healthcare equity initiatives. It allows that person to have responsibility for those activities and oversight. They don't necessarily need to be doing all of the work themselves, but really just making sure that there is an accountable person, again, that oversees the initiatives that are going on across your organization. You can consider how, again, equity initiatives are coordinated, because depending on what your organization focuses on, it may include some IT or data collection. There could be some staff training issues. Again, some other opportunities to work with quality improvement and risk management. So we wanted to make sure that there was somebody that was designated from an organization to oversee those issues. The hospital can assess the patient's health-related social needs and then provide information about community resources and support services. So this is EP2. This again is focused on identifying those health-related social needs to help reduce healthcare disparities and improve outcomes for your patients. I will say there is a lot of flexibility built into this requirement. So organizations, again, have the opportunity to determine which patients they want to do these assessments for, which health-related social needs to include in those assessments, and then which resources they want to provide to patients around their health-related social needs if they identify something. You can also focus on a representative sample of patients in your organization, or we also know that some organizations are routinely collecting health-related social needs for all patients. So again, there's a large span of activities that we're seeing across the country. So there is a lot of opportunity here for organizations to make sure that this requirement makes sense for where they are right now. The other key point here is to make sure that not only are you collecting information around patients' health-related social needs, but you're also connecting patients with resources and support services in the community. There's a lot of different ways organizations can do this. Again, we know there's some organizations on one end of the spectrum that have very sophisticated electronic closed loop referral systems, and that would work here. But there's also organizations that'll be providing information around community resources through the patient portal, or maybe through pamphlets or other documentation. So again, there's a lot of opportunity here for patients or for organizations to make this work with what their systems currently are. And then again, to think about improvements that you can make along the way. We also have a number of resources in our resource center, and I'll talk a little bit about that towards the end of the presentation, but I just put a couple of things in here. Again, there's a lot of flexibility here in terms of what tools that you choose to use for your assessments. Again, which questions you want to use is really up to the organization. One of the neat things that our Department of Research did when they were compiling these different tools is that they created this question bank document, which is a PDF that you can download off of our website. And it has kind of an overview of all the major tools and most frequently used tools that are in the field, and pulls out those questions that are specific to food insecurity or housing insecurity. So again, it gives you an opportunity to take a look at what questions are currently being used, and then you can either use one of those questions directly or modify it depending on your population. EP3 is focused on identifying health disparities within your patient population and stratifying your quality and safety data using the sociodemographic characteristics of your patients. So again, there's an opportunity here for you to understand which processes and outcomes may be varying based on certain sociodemographic characteristics, and you're seeing differences in one population over another. But there again is a lot of flexibility here for organizations to decide which measures they want to stratify and which sociodemographic characteristics they want to use in that stratification analysis. So organizations, again, depending on the type of organization you have and the different patients that you're seeing, you can focus on high risk topics where we know in the literature there are known disparities. So if you want to focus on maternal health or diabetes, for example, you can do that. Or you can select measures that affect all patients. And take a look at your communication measures or experience of care information, and then stratify that by the different sociodemographic characteristics of your patients. We have some examples within the note to EP3 that give some ideas around sociodemographic characteristics, but it can be, again, what is relevant to your population and which different areas that your organization is choosing to focus on. So you can do this by race and ethnicity, you can do this by age or gender. It really depends on, again, where your priorities are as an organization. And our surveyors will just be looking for, which measures did you choose to stratify? How did you stratify those measures? And then what type of disparities did you identify? And then the further requirements here, we'll talk about what you've done with that information once you've identified a disparity. So EP4, and once you've identified that you do have a disparity within your patient population, we're looking for organizations to develop a written action plan that describes how you would address at least one of the disparities that you've identified. And we know some organizations can do very sophisticated stratification analysis. They have a number of different data points, and they may uncover multiple disparities. This requirement is just about identifying a priority issue, one disparity that you as an organization want to work on, and then creating an action plan around that specific issue. The action plan should just include what are your specific population or populations of focus, what your goal is overall to improve, any strategies or resources that you'll be using to achieve your goal, and then also a process to measure and report progress. And so you want to make sure that what you're doing is effective. We've had a number of questions about, is there a template for this action plan? Do we require a specific format? And again, it's really up to the organization to figure out how you want to capture this information and present it to your surveyor. We do have a couple of resources that are available on our resource center, some examples of tools that you may want to use. They're very similar to what I just talked about in terms of those different categories and different data points, but it can be arranged again in however your organization chooses to do so, or maybe you already have a template for an action plan for some of your other patient safety initiatives that you might be able to use in this case as well. And so once you've made your action plan, we also want to make sure that organizations act upon any situations where they don't achieve or sustain the goal that they've identified in that action plan. So that's why it's so important within your action plan to have some way to measure and track your progress, so that if you find that perhaps you're not being as effective as you had hoped, there's this opportunity in EP5 to make sure that you can make changes to that plan. And you have a number of ways to identify opportunities to revise your plan or to provide additional resources to help with those goals. You can go back to your stratification analysis again and see if you're making progress. There's opportunities to collect feedback from patients about some new services or interventions you may have implemented. So for example, if you're focusing on something around language services and you've changed language service vendors, or you have more interpreters out on the floor, you may be able to ask patients and their families about how that's working and what their level of satisfaction is with those services. And then you can also evaluate staff training or other educational needs, particularly around areas maybe around data collection. If you're looking at the way you're collecting different data points for patients, race, ethnicity, for example, there may be some opportunities to provide additional training to staff or resources or tip sheets or things like that to make that process a bit more effective. And then of course, EP6 is just sort of rounding out the entire standard. At least annually, we want organizations to inform key stakeholders, including their leaders, licensed practitioners, and their staff, about the progress that they're making to reduce the identified healthcare disparity. Again, this is just making sure that your internal team is aware of what your organization's initiatives are to address disparities, and that they understand what their role might be in those larger initiatives. It's important to receive updates about not just the challenges that you're facing in terms of achieving those goals, but also the successes that you may be encountering as well. And that can be done through, again, a number of different ways. Organizations can do this through presentations, quarterly meetings, town hall type of events, or also through newsletters, progress boards, and your intranet page. It's really up to the organization to determine what's the most effective way to present that information to your staff. I mentioned the Resource Center. One of the unique things with this project is we had an opportunity to not just develop the new requirements, but we also had a team that was looking at resources to help with compliance with each of these individual elements of performance. And so in the past, again, for those of you who have followed our projects over the years, sometimes we'll be able to release a roadmap for hospitals, which we did about a decade ago around healthcare equity issues. We've had some different compendiums of resources that have followed projects that were, again, download documents that you could get off of our website that had practices and other resources to help with implementation. And one of the exciting things about this project is this is actually a whole new website that we have on our off of the Joint Commission webpage that just focuses on resources to support standards compliance with this particular standard. And what you can do is when you go to the page, you can click on these individual navy blue boxes and then go straight to the resources that are related to whatever element of performance you're focused on. So you can look at all of them, or if you just really are struggling with how to do that stratification analysis to identify healthcare disparities, you can click on the button. Unfortunately, it's covered by this other graphic I have here, but this one behind here is EP3. Just click on that and it'll take you directly to a series of resources and strategies to help with identifying healthcare disparities. One of the neat things on the site is that our team that developed the Resource Center also was able to go out to a number of different organizations that have implemented these issues and have a lot of lessons learned and different, aspects of their experience to share. And so they've been able to put up these snapshot documents, which are kind of a 1 to 2 page summary of the case study organizations that they went to. There are a series of sound bites here, so brief videos. If you're more of a podcaster, you prefer to get your information audio, you can listen to these sound bites again that have some real gems from organizations that have implemented some of these different issues and things that they may have learned along the way. And then there's a whole section on strategies, which includes some of the tools that I showed in previous slides that give you links directly to some of the other tools, the other examples that are out there in the field. Just coming soon, we do have this standard in the leadership chapter. You may have seen some articles about this already. In order to continue the focus and the priority level around healthcare equity initiatives and our requirements in this area, we are going to elevate this leadership standard to a national patient safety goal in July of 2023. So it'll move from LD 040308 to NPSG 160101. The requirements will be very similar. All of the EPs basically have the same expectations. There's some nuanced language changes that you'll notice just because of the way that we write national patient safety goals, but the real expectation and the core expectations of these requirements are the same. And all of the resources that we have on the Resource Center supporting the leadership chapter standard will also support these same requirements in the NPSG. And then we also, again, we were very busy last year with the accreditation projects, and we also developed a new healthcare equity certification program that will launch also in July of 2023. This is a voluntary program for hospitals, again, separate from our accreditation programs, that builds on those requirements that we've had in the manuals for years, builds on top of this leadership chapter standard, and really recognizes organizations that are striving for excellence in this area. It's a freestanding program, freestanding certification that looks just at healthcare equity issues and initiatives, and again, and hopes to continue to identify organizations that excel in this area. So with that, I can open it up for questions. I think I'll take a look at the chat as well, but if you think of a question either after this presentation is over or you don't want to ask it in the chat, you can also submit it directly to the Joint Commission through this link here, and then the questions will go to likely to me back at the Joint Commission, and we'll try to get some answers out to you as well. So let me see if I can open up the chat here and go back up here. I know there was a lot of questions earlier, as well as some questions and some folks writing in with who they are and where they're from. it's always nerve-wracking when you see the chat numbers go up like that. You're like, oh, what did I just say? But I think there might be a couple of them in here. So I'll take a look and again, encourage any of you on the call to continue to write them in again, or send them directly to this link.
Yeah, there's one additional question for CMS that we'll send because Julia had to drop off.
Okay.
But there are a few at the toward the bottom for you.
Okay.
Starting
Here's is a Stephanie's question, I think. Can the leader be at the system level for EP1 or a multi-system hospital? I failed to mention that earlier. Yes, it can be. If you're in a corporate system or you have multiple organizations, you can have a system level leader identified for EP1. I think, again, that's really about oversight of the initiatives as a whole. The one thing that we do caution about that is you can do that, but I think it's also important just to make sure that that individual understands the nuances at the different sites. There may be some differences in, what the initiatives might be, the way they're implemented, some differences in the patient population. So that's just one thing to keep in mind, but that can be assigned for EP1 at the system level. Do you see CMS, the SDOH measures that Julia talked about earlier and the data collection supporting EP2? Absolutely. I mean, we have some slight differences in some of the examples that we have in the note about what you can collect around SDOH. But again, it really is up to organizations to figure out which health-related social needs they want to include in their assessments. And I do think there's overlap here, definitely. We have, again, there's a little more flexibility, I think, on our accreditation standard, just in the sense that you can identify which patients you want to include in the assessment. So again, some organizations will be doing this routinely, and some will be focusing in on a specific patient population or specific area of your organization. So you may want to focus on the emergency department, for example, or again, maybe you want to focus on OB patients. So for us, you can do that at this point, because again, we just want organizations to start to collect this information and implement their systems to be able to capture this information, and then again connect patients to resources that would address those specific health-related social needs that they're collecting. There's a question here about organizations that don't quite yet stratify their own internal data. Can they leverage third-party data or community-based data? I think you can start. The goal of EP3 is to identify potential healthcare disparities within your patient population. So you still want to be able to stratify the sociodemographic characteristics of your patients. Again, we want organizations to just start to do this if they haven't already. So we know that there may be a bit of, again, a spectrum of things that our surveyors are going to start to see out on site. But again, we just want to make sure that organizations can identify a quality and safety metric that they want to explore further, and then start to get into that data analysis within the sociodemographics of their own patients. But again, you can choose which sociodemographic categories you want to use. So if you're not collecting a lot of information, or you don't have, again, a lot of information on one specific demographic area, you could use a different one. And again, it doesn't necessarily have to be race or ethnicity. You can look at age, you can look at gender. We're really just hoping organizations can start to do this type of analysis. For these two sets of requirements, I think there's a question between EPs, maybe for 3, do we have till the end of the year to have them implemented? For organizations that are surveyed at the beginning part of 2023, so those of you who may have experienced your survey already in January, maybe the first few months of 2023, the only standards that we have maybe a little bit of a time delay on are EPs 5 and 6. The rest of them, our surveyors will be expecting to see what your organization has done around collecting health-related social needs, how you've stratified your data. But if you haven't had an opportunity to make changes to your action plan, because maybe you've just implemented something and you don't have enough time to implement it to see if it's being effective or not, then for EP5, you could discuss how by the end of 2023, you could discuss with your surveyor, what your plans would be to adjust your action plan, depending on, again, what areas you may find are opportunities for improvement. EP6 is similar. If you haven't had an opportunity at the beginning part of 2023 to inform your internal stakeholders about progress because you just started a project, or you're just in the beginning phases of implementation, you can discuss with your surveyor that, by the end of 2023, these are the types of activities that we would do to inform the staff about, what our different healthcare equity initiatives are, what the progress has been, or identify feedback from the staff as well. Is there a possibility to get a list of the standards that currently address this? These should be in your manuals now because they were implemented in January of 2023. They should be embedded in your e-edition, or if you get the print manuals, it's in the leadership chapter, LD 04, 03, 08. I will say too, I didn't have a slide about this. We also released an R3 report. So for those of you who are familiar with that, it's a couple of pages, maybe 3 or 4 pages. It's R3 stands for requirements, rationale, and references. And so that provides a nice breakdown of each of these elements of performance that I just talked about today, along with a bit of an intro content about what the rationale was for that requirement, as well as some of the references that we use to develop the requirement. And then again, I encourage you to go to the Resource Center and that online website, because that has a much more elaborate set of resources available to help with implementation. There's a question here about what will surveyors look for to determine compliance with these standards. Again, depending on the requirement, it's really about making sure that you as an organization have identified a leader for EP1. EP2, we just want to learn a little bit more about how you're addressing or how you're assessing health-related social needs, again, which populations you're focusing on, which areas of the hospital you're focusing on, which needs you're including in your assessment. I want to know a little bit more about what the assessment is and how you've implemented it. In terms of EP3, we'll want to know which metrics you chose to stratify, what you use for your stratification analysis, what healthcare disparities you've identified. And then again, as it keeps moving forward through the standard, we'll want to take a look at your action plan, again, see what's in there, how you're working with that, what strategies you're implementing. EP5 is any changes that you may have made to your action plan. So I want to hear a little bit more about how you identified opportunities to make those improvements, and then what changes that you made. And then 6, again, would be more about how you're identifying chances to talk to your staff and provide updates, again, to internal stakeholders about your initiatives and your progress so far. Saw a question here about the R3 report. It is on the website. So if you go to the Healthcare Equity Accreditation and Standards Resource Center, I think this is the long version of it, you'll get access to those navy blue boxes that I showed to get you to the different resources by EP. The R3 report is on there, as well as an on-demand webinar. If you're looking for longer content, we did provide a recorded webinar. It's about an hour long that has basically me talking about these standards, as well as some demonstration and some key points from the team that developed the Resource Center, talking a little bit about some of the features of the Resource Center and different things that they have on there to help with the standards. So there's some additional content and support on that resource page as well. This is kind of a long one, but if a healthcare organization identifies during data collection, they have high food insecurity, what's the next step to address the finding? I mean, I think, again, this is really about what your organization is doing just in terms of connecting patients who may have food insecurity and that they're identified on the assessment, connecting them with resources in the community. So it's not necessarily that an organization has their own resources to address food insecurity. Some organizations do, which we think is fantastic. So again, that would be well within compliance with the standard. But we know some organizations are just not at that point, or they just don't have those structures in place. And so I think the goal of EP2 is just to make sure that you can identify health-related social needs in your patient population of focus, and then connect them to resources that can be resources in the community. And again, I mentioned there's a number of ways to provide that information. It doesn't necessarily need to be electronic closed loop referrals. It can be presenting that information through a number of different mechanisms. I think that might be it as far as questions. I'll stop sharing so we can open it back up, and I will turn it back over to Laura. But again, thank you for your attention. If you have any questions in the future, again, there's that link on the website.
Thank you so much, Dr. Cordero. I really appreciate it. Sorry, I have to scroll through all these slides. So I just wanted to wrap up today's event by just saying, if there's any additional information that we can provide, please feel free to reach out to my colleague, Stacy Doris, or myself. Stacy supports the HQIG contract. I support the QIN-QIO contract. We're happy to help. Also, this is the link to the iPro website. The slides and the recording from today's event will be on the website. Additionally, we'll be sending out a PDF of the slides, and I believe Joy is going to be sending me some additional resources that I'll also include in that email to all folks who attended today's event. Thank you very much for joining us today. We hope you found it very helpful. Enjoy the rest of your day and enjoy your weekend. Thank you.